from 12 to 1. So we don't have a case submitted for today, but we'll just jump right in. Dr. Miller has prepared a presentation for us, so we'll do that for the first about 20 minutes or so, and then we'll go into some Q&A right after. So Dr. Miller, I'll pull up your PowerPoint on my end. Just let me know when you'd like me to advance the slides for you, and I'll turn things to you now. Thank you. And Dr. Miller, I believe you are muted right now.
How's that? Better?
That's
okay.
That's perfect. Thank you.
So you can see the title of my talk. This is the continuation of a talk that I started last fall. So if you could go to the next slide. Here's the agenda for today. So we're going to do a quick review of what I talked about last time in case some of you might be new. And I'm going to use my own illustrative case mini vignettes, and they're going to focus on some common areas that we often struggle with patients and caregivers: driving issues, finance issues, caregiver conflict, caregiver impairment, alcohol use on the part of the patient, and comorbid depression, and finally, a word about last will and testaments. So next slide. We'll go through these a little bit rapidly since it's a review. So the spectrum of cognitive impairment, nobody gets demented overnight unless you have a massive head injury or something. Most people have a degenerative disorder, and between normal and dementia, there's this gray range. Now we call it minor cognitive impairment, where you're starting to lose function, but it may not be obvious to everybody. And now it used to be that you had to have memory loss to call it dementia, but now you don't. You can have executive dysfunction, which often precedes memory loss. And families often misinterpret this as problem behaviors, opposition, laziness, meanness, falling out of love. They don't know what they're seeing until we point it out to them. Next slide. So here's executive function dysfunction examples. So all of these things require an intact frontal lobe and all the circuitry that connects the frontal lobe with other parts of the brain that allow you to do these, what are really complex tasks on this page. And when your brain function is missing, then you can not be able to do one or more of these on this page. Next slide. So the caregiver is not the patient, but they're integral to managing the identified patient. So our job is to educate, advocate, refer the caregivers for their own help sometimes. And we also need to acknowledge that the caregivers are going through their own role transition, perhaps from a happy-go-lucky adult child to now one who has to worry about their parents and check on them and fight with them when they don't want to do what they want them to do. Next slide. So caregiver issues, we work with them insofar as it impairs their ability to give care. If we see a caregiver who has their own problems, we want to resist getting into treating them, even if we think we can, because we want to keep it separate. And I'll tell you why. Occasionally, we have to point the finger at the caregiver if they cross that line and become abusive. And it does happen occasionally. So we want to keep that sort of demarcation that we're working for the identified patient. We'll work with the caregiver insofar as they're trying to help the identified patient. But if we, if we sense there's elder abuse, we may have to change course. So we want a better bridge of understanding, and we want to provide a forum to resolve conflicts. Next slide. We'll show you some examples of that coming up. So sometimes the caregivers, we need to start by saying, look, yes, your loved one has changed. Try to meet them where they are, not as you remember them or wish them to be. It'll be easier if you do that. Sometimes you have to modify your expectations. They're never going to drive again, or they're never going to do something they were really good at, perhaps. Be careful with the tone you say to the caregivers. Be respectful, because oftentimes they're very aware of their deficits and feel bad about them. You want to allow yourself to grieve sometimes, because you can lose the person right in front of you, but they're not dead. They're losing their essence of what makes them special or why you fell in love with them, etc. And then finally, sometimes acknowledging old hurts can be a problem when you're caring for, let's say, a parent who was once an abuser. That's a weird situation, but you sometimes see it and have to deal with it. Next slide. So this is a book I wrote in 2009, adapting a form of psychotherapy called interpersonal for use in late life with this population. Next slide. So in this, IPT was developed for treating depression, but I argue that it works just as well for cognitive impairment. And that really, when we see a new elder, the sum total of their functional capacity really is affected by whether they're depressed or not, whether they have cognitive impairment or not, whether they're physically disabled, and then finally, whether they have an adequate support system or not. So all of these things factor into, how they're doing. Next slide. So in geriatric depression, I would argue, or cognitive impairment, we essentially do the same thing. We engage the patient, we engage the family, we educate them, we work them up for medical contributing problems. We treat them if they're treatable. We use psychotropic medication and provide a lot of psychoeducation and perhaps psychotherapy to do what we can to shore up the situation and help maximize their function. Next slide. So in summary, in IPT, we engage the patient, we educate, empathize, strategize, sort of brainstorm, if you will. We use flexible or joint meetings, either with the patient alone, the caregiver alone, because sometimes that's important if the caregiver is paranoid and accusing if the patient's paranoid and accusing the caregivers of taking their money, etc., we need to help them by meeting alone, and sometimes joint problem solving, and I'll give you some examples. We want to seek what I call a steady state, which is a term I borrowed from physics, which means basically they get to the point where they've been worked up, they understand what's going on, they're on the proper medication, and they're kind of cruising. They're not at a level they once were, but they're sort of steady month after month, and you might stay that way for a couple of years before the disease takes another downward turn and you have to reset what your strategy is. So we, the providers, are long-term advocates in what's likely to be a downhill course and perhaps all the way to death, and helping the family cope with that. So we want to anticipate the future and at some point talk about end-of-life planning, which I'll get back to. Next slide. So again, we integrate the caregiver into the treatment. We do psychoeducation. It might be different for the caregiver or the patient. And sometimes we do problem-solving sessions, and sometimes we kind of enlist the caregiver as a coach to be an extension of us to try to steer the identified patient in a certain direction we think is good for their overall health. Next slide. So practical questions to ask caregivers when it's early on and you're trying to assess, are they functioning or are they not functioning very well? Are everything on this list? These are basically instrumental activities of daily living, but also is there risk? Is there fall risk? Risk of having a fire with accumulated newspapers all over the house? Can they operate appliances safely, or is it dangerous? Should they not be mowing the yard with the tractor anymore? I had one patient who rolled the tractor over on himself because he misjudged, how steep the hill was. Are they at risk for scams, which are everywhere these days? Is there someone who has medical power of attorney or financial power of attorney? And if not, it's probably a good idea to get them. And then finally, where as a caregiver would you draw the line where you say, I can't let my mother or father live this way anymore. I have to take action. So these are different points for different people, and you open the discussion. And then finally, what resources are available to help? Next slide. So here's the first case vignette of mine. And this was an actual patient that I don't think is identifiable that we saw in our clinic. The patient's daughter is overwhelmed. She lives out of town. Her mother's in the Morgantown area. And her mother's going downhill with cognitive impairment, and she has several medical problems, severe diabetes for one, and she's on a bunch of different medications for that. And the daughter actually tried moving her in with she and her husband. Didn't work out very well. Mother's very strong, kept them up at night. They had to get to work. They said, this isn't going to work. So now patient's back home, and two things have happened. Neighbors are saying mom is driving across the yellow line, and nobody wants to ride with her anymore to get her groceries. And also she has no idea that she's supposed to be on a bunch of medicines. She doesn't think she's on anything. So it's kind of a critical point where something must be done and resources need to be identified, and the patient, the caregiver needs a lot of help. How do I get help out of state? What do I do? How do I confront my mother who's very headstrong? And that's where that discussion needed to start. Next slide. Go ahead, next slide, please. So here's another no insight into finances. This daughter was living with her aging mother, who was always very headstrong. This was a family that I knew when I worked in Pittsburgh. They were African American, lived kind of a meager existence on not much income. And bill paying was critical for both incomes. The daughter worked and also had a child at home and going to school, and mother had a small pension and Social Security, and they needed both incomes to pay the rent. Well, mother was starting to get demented and was buying things on Home Shopping Network, and the daughter was saying, Mom, you can't do this. We can't afford it. And mother was very defensive, saying, it's my money. I'll do what I want. And so there was very much a role reversal going on, where daughter really was reluctant but needed to step up and be the, quote, responsible adult in the house. Otherwise, they were already having bill collectors calling the house. So I tried successfully to do what I call a finesse move. And that was to try to convince the mother that the daughter needed to step up and learn how to be responsible, and that she should put her name on her accounts so that she can manage the money and get practice. Because from a little girl, mother would sort of always took care of her, and it was time for her to grow up and do it herself. And mother sort of bought that and agreed to it. So then the daughter took over the finances, and at least they had a roof over their head. Next slide. Driving safety talking points. This is a tough one. In today's cohort, mostly men have the biggest problem with driving because it's tied in with their masculinity and their working self and the bring home the bread view of themselves. So sometimes when it's time to stop, I try these things. You do want to retire your license with a perfect record, not wait till you have an accident like some people do, right? You say to the patient, everybody needs to stop at some point, and to point out that a lot of body systems have to work together to drive safely. And if one of these is out, or one or more, then there's a problem. And you can fill in the blank with, in your case, your vision is bad, or your memory, or your remembering where you're going is impaired, and that can lead to having an accident. You want to think about alternative transportation plans ahead of time, so you can say, don't worry, so-and-so will drive you, or you can take the bus if you live in somewhere where there is a bus, etc. Next slide. Combining medication with intervention. This is often the real world. So demented patients are often impulsive, quick-tempered, demanding, short-sighted, and caregivers don't know what to do about all that. And so helping the caregiver understand that empathy, for example, requires intact brain circuitry, to allow the person to look at the world through someone else's eyes. That's an abstract concept, and you lose that when you start to get demented. So they'll say things like, you know, he never asks about my day anymore. He doesn't care. He just wants to know when dinner is. Well, that's because he has trouble empathizing. Okay. So sometimes serotonin boosting drugs like our Prozac, Zoloft, these can work miracles in calming this kind of impulsive, quick-temperedness. And so we use them judiciously, and how to use them is, of course, the art of psychopharmacology. The memory enhancing drugs that we have on the market, Aricept, Namenda, and similar ones, they can also improve clarity of thinking. And don't forget, what they're doing is improving the communication between different sets of neurons in the brain that need to talk to each other to do complex action. So sometimes you see a bump of improvement, but even if you don't, they're really preventing further slide down is the reason we give them. So if families say, you know, we took that memory drug for 3 months and memory is no better, so we stopped it, say, not so fast. It probably is controlling them getting worse when you compare it to groups of patients who had a dummy pill in actual studies. So sometimes you have to drive that point home several times. Finally, low-dose antipsychotics, we don't like using them. It increases the risk for heart attacks and strokes a tiny bit, can cause tardive dyskinesia, you know, mouth movements that are disfiguring. But in some cases, you have to because the risk is worse, and I'll show you examples of that. Next slide. So here's a wife faces uncharacteristic aggression. This was a patient I saw in Pittsburgh. A husband was a mild-mannered retired teacher, but he was having violent outbursts toward his wife. He would get so mad, he would get red-faced, and one time he tried to choke her with a towel. And she didn't tell her family for the longest time because she didn't want them to think badly of him. So one thing we had to stress is that you have to tell your family. They need to know this. And if you're being threatened, you need to leave the house right away until you're safe. Let him cool down, get help, come back. You know, practical advice like this, you know, don't be the martyr here. You can get hurt with somebody who's not their right mind. So he would forget that he did it, and then she would forgive him, and you know, it was a dicey situation. What also seemed to trigger these anger outbursts is their daughter was going through a divorce, unfortunately, and they would discuss it around the dinner table, and he got the idea in his head that he was going to have to pay for her children growing up and going to college, and it was going to bankrupt him. And no amount of saying that wasn't true changed his mind, and he got so upset that one of our suggestions was don't talk about the divorce in front of him. He can't process it. It's too complicated, and he's misinterpreting it down the wrong path. So once they did that, it helped a little bit, but he was still having anger outbursts until we put him on a little bit of Risperdal, an antipsychotic, and he mellowed out just like, you know, a lamb. Never had another aggressive impulse. So sometimes these medicines work charms, like a charm. Other times, not so much, and we have to pull out other stops. Next slide. Alcohol is a given. Here's another case I saw in Pittsburgh, a 7-year-old retiring physician. Retiring is the operative word. He was still seeing his old patients in the house. They would call up. He would write prescriptions. He had a cabinet of drugs in the basement that he would dip into himself sometimes and self-medicate. And he was drinking. He drank 2 highballs before dinner for 30 years. Said, it hasn't hurt me then. It's not going to hurt me now. But now family notices slurred speech, impaired gait, and demandingness and hostility. So finessing the situation can be tried. You can buy non-alcohol beer. You can mix the highball yourself. And basically, if you put just like a drop of alcohol on the top, it still smells like gin or whatever. But oftentimes they can't tell the difference in taste. And they have the same sort of ritual of the convivial cocktail hour without the alcohol effect. So these things can be tried. They don't always work like you hope, but at least it gets the caregivers thinking about alternative strategies than just trying to say no, which creates a fight. Next slide. Here's one where the caregiver was impaired by alcohol herself. So this was an out-of-work daughter who moved back with her dementing mother. The mother came to us for the first time, brought by this daughter plus an older daughter who lived nearby with her own family. And we assessed her, and I noticed through the whole interview, the elder daughter did most of the talking. The dementing patient agreed, and the younger one said nothing. And finally, at the end, I asked her, "Do you have anything to offer? You're living with your mother." She said, "No, whatever my sister said is fine." So before she came back for a follow-up visit, the older sister called, said, "I filed a protection from abuse order against my own younger sister because she's an alcoholic, and she moved home and she's berating my mother every night, getting drunk and shaking her down for money." So those are situations that are part of life. We're going to see them. Just because someone's getting demented doesn't mean they're immune from them. And sometimes we have to step in and give our advice to seek a remedy. Next slide. Here was one case, a near disaster averted in Pittsburgh. This was a famous case. It wasn't even my case. It was on the news of a mother and father living with their schizophrenic son. The son never left home, but husband died, and mother went on to become demented. Well, she neglected to take her son to his mental health appointments. He went off his antipsychotic, and she got more demented, and he got more psychotic, until the neighbors noticed, something was wrong. They investigated and found she was tied to the banister like a dog because she was incontinent and soiling the furniture. And that's all her psychotic son knew how to do, to keep her from soiling the furniture. So it's a tragic situation. Could have been fatal. But they both got hospitalized. He went to a group home, she went to a nursing home, and at least they had decent quality of life from there. Next slide. So caregiver referrals, sometimes they need their own mental health, maybe substance abuse health, often legal help. So it's important to know who's making the decisions. Is the identified patient still think they're making decisions, and are they good or bad? Is there someone else in the family other than the person in your office making the decision? Because it's important to know. Out-of-town caregivers call all the time. They're trying to be dutiful, and they fret long distance, and we have to do what we can, hooking them up with services. Again, we mentioned old parental conflicts, personality styles, headstrong patients, identified patients often don't want to hear anything from their kids because that's the way it's always been. So it's very hard to switch that. One case we had was a patient who was probably bipolar her whole life, but never diagnosed till she got onto the geriatric unit. Very manic and very demanding and bossing everybody around, and took a while to get her mania down to a normal level of mood. And then she became quite docile. And for the first time in her life, her very meek daughter, who was afraid to had to walk on eggs around her, finally could manage her mother, who now was a lover of cats and spent all day petting her cats. And the daughter could control things for the first time in her mother's best interest, and did a very nice job of it. But it was very interesting to watch the total transformation of the hierarchy of kowtowing to her mother, to the point where she was now medicated and manageable, even though it took till she got demented and hospitalized to figure it all out. Next slide. We have a couple more cases, and then we'll open it up for discussion. So I've seen in my career a lot of cases where time to leave is not heeded by the dementing identified patient. So, for example, CEOs of corporations, heads of family businesses, it's becoming obvious to everybody that they're slipping. they're not making good decisions. Maybe they're even making ruinous decisions for the company, but everyone's afraid to cross them. So they quietly tiptoe around and debate whether they should have a hostile takeover and put someone else in charge. Occasionally, I've had the success suggesting that they have a grand retirement party. You know, it's kind of akin to somebody who takes too long on stage and they come out with that hook and pull them off stage when it's time to move on to the next act. But sometimes if the family gets into the rhythm of it and they, you know, have a huge party, thank him for everything he did and built the company, etc., at the same time make it clear that he's retired now and i.e. don't need to come to work. I've had other patients who retired successfully and come back and say hi to everybody and have a sort of emeritus role. You know, they come back and kick the tires of the machinery, or one guy owned a dairy and he'd come around and visit all the farm hands and say hi, and, you know, that was a new role for him, which was appropriate at his level. One case I had of a man who had, this was here in Morgantown, he was involved with 3 different businesses and a very go-getter type of guy. His wife knew nothing about his businesses. She had her own career, and he was getting more and more demented. And at one point I said, I need to see your wife to come in with you because I need to understand the big picture. And I said to her, look, do you know what's going on with his part of these businesses? Because I don't see how he can follow them. He's getting too demented. I said, do you have legal advice? And she said, no, I don't really know anything about his business. I said, well, I think you better learn. And so, to make a long story short, she did get legal advice, and it turned out his partners were ripping him off. They were taking advantage of his slipping cognition and enriching themselves at his expense, which was her retirement based on her right to have his share of the companies. So it can be complicated, and obviously it's not our job to figure it all out, but it is our job to point them in the direction where somebody can figure it out and preserve their rights. Next slide. Available money begets greed. That's an aphorism I just made up, but you see it a lot when it comes time for last will and testaments. And I've been involved in several cases where there's a estate. You know, if you look at where all the money is tied up in the population, most of it is in the hands of older people because they've accumulated it their whole lives. So it's common for distant relatives sometimes to show up. In one case, an aging man living alone, they came and sort of took care of him for the last few months of his life because he had a terminal condition. 3 days before, they had him sign a new will, giving them everything in his estate. And so the lawyer asked me, I didn't even know this patient, but he asked me would I review the records and see if I thought he was in sound mind to sign a new will. And I said, I don't know if I can tell that from the records, but I'll take a look. So I took a look, and sure enough, he was being visited by the visiting nurses 3 times a week. And every note that they had for the month prior to his death was how disoriented he was, didn't know what day it was confused. And they documented it. And I concluded I didn't see how anyone could say he was of sound mind and body to sign over his estate to somebody else if he was confused every day based on these nurses' notes. And the judge threw it out. So the previous will then came back into action. So again, we're not lawyers and we're not sleuths or private investigators, but when you see things happening that involve or an effect of the dementia, sometimes we can steer them in the right way. And one other case will illustrate that. One of my kids went to high school with his father was a judge. And so we met socially, and he called me up one day and said, I need some help with this case. I don't know what to do. This old man, you know, the family, kids are fighting over his estate. his will. He doesn't have a will, and he has quite a bit of money. You know, would I evaluate his competency to make a will? And I said, well, I'll try. And so he came to my office with two warring camps, two children who were fighting that they should get a lion's share of the estate, and their lawyers. And they all wanted to come in and sit on the evaluation, which I said, no, I'm going to see him by myself, and then I'll render my opinion, and I'll send it to the judge because he's the one who asked for it, and you can just wait out here in the waiting room. So I did that. And I talked to the older gentleman, and he was confused. He did have dementia. He didn't quite know how much money he had or where it was kept in which banks, etc. But I said, do you know who you want to will your money to? Because when when you die, you have the right to do that. He said, yep, I want it to go to my nephew because he came and visited me every day for the past 5 years, and my kids were never to be seen. And they're now showing up fighting over my money. So he understood that much, and he understood who his nephew was. And so I said to him, look, do you know that you can make a will and keep it secret until after you're dead? Because he didn't want to fight all those people in the waiting room. And he said, no, I didn't know that. I said, yeah, it's true. So I wrote a letter to the judge saying, yes, he's demented, but he's not so demented he can't pick his the person he wants to will his estate to, and he picks his nephew. And so I would suggest you appoint a lawyer to him to write up his will, and he also wants to keep it secret till after his death, which is, I understand, is his choice. And the judge agreed to it all. So I don't know exactly what happened. I never heard back, but hopefully justice was served and his money went where he wanted it to go. So the long and the short of it is, when you see someone with early cognitive impairment, if they don't have power of attorney, if they don't have a will, it's a good idea to get it before they get too far gone and can't understand it. And what I have done in my notes is when they say they're going to go give a will, make a will, I write in my note, patient says he wants to go see a lawyer and make a will, and I think he's of sound mind and body at this point in my judgment to do so. So that if it ever gets contested later and they come back and review the medical records, they have me on file saying, I thought he was competent to do that at that time. Because everything can be twisted with greed is driving the bus. Next slide, please. So that's the conclusion of my little talk and my cases. Of course, the Alzheimer's Association is a resource at all times, and they've heard these cases in similar ones as well, and they can be reached and reached out, and caregivers can be referred to them. Next slide. Here's another set of references that other people have used that you might want to recommend for your caregivers. So I'll stop there and take questions. Lots of little case vignettes were thrown around, and I'm happy to hear your own versions or expand on any of these themes as you want to hear more. So just tell me what you want to hear and we can discuss. Thank you.
Awesome. Thank you so much, Dr. Miller, for doing part 2 of your presentation. Before we jump into any questions or feedback and stuff, I just wanted to also acknowledge that we had some new participants join while you were going through your PowerPoint, so just wanted to give them a chance to introduce themselves as well. Dr. Pollywall, I'm not sure if you're in the room there, but we wanted to maybe give you a little intro as well if you wanted to unmute and introduce yourself to the group.
Thank you for joining late. I'm Dr. Himanshu Paliwal, Family Medicine at Fairmont.
Awesome. Thank you so much. Glad you could join us. And we also have a username, AEH10053. Feel free to unmute or chat in as well. I see that you unmuted, but we are unable to hear you. So if you could chat in, that would be awesome. Thank you. All right, did any of the hub members have any other comments or thoughts that they wanted to share with the group? Feel free to unmute as well.
I'll just make a comment. That was really great, Dr. Miller. Thanks very much. I think that was also a great reminder of how some patients may not have capacity for certain decisions, but that doesn't mean they don't have capacity to make any decisions like wills and things like that. So I think that's really helpful for all of us to remember.
Yeah, so I'm not a lawyer, but the ones I have spoken to tell me that, you know, competency is with regard to which question you're asking. So you're right. Somebody may not be competent to, you know, negotiate the sale of a company, but they still are competent to make a will and decide where they want their personal estate to go to, something like that. So again, you know, sending them for legal advice is what I do pretty early in the process, rather than, I want to be careful I don't lead them astray with something I may not understand. But so our legal colleagues and elder law specialists are good to know in your community, because not everybody is familiar with elder law. And the ones that are good at it are used to writing, you know, medical power of attorney and preparing things for guardianship. And by the way, for those who may not know, medical power of attorney is when you're of sound mind and body and you can pick who you want to speak for you if you become too ill to do so for yourself. And ill can be mentally or cognitively impaired as well. When to launch that is sometimes a dilemma. And the MPOA said, you know, I don't think I should let my mother or father do that. And they say, why not? And they want to. And that's at some tipping point, the one with the MPOA has to override and say, no, I'm gonna step and do my duty here as power of attorney and not let you do that, Mom. I'm sorry. And so it sometimes does lead to a fight. The guardianship, on the other hand, is in West Virginia, they call it guardianship, and they separate conservatorship as being someone appointed for financial responsibility. That's not what the patient chooses. That's what a judge chooses based on the testimony of experts, which includes our mental health opinions. That they take away the rights of the patient and hand it to somebody else who will hopefully advocate in their best interests. So that's the difference. So the guardianship is when they're too far gone. Sorry.
No, that's awesome. Thank you so much. I just wanted to thank Dr. Ward as well for that comment. Teresa, I noticed you unmuted. I didn't know if you maybe had a question or a thought you wanted to share with the group.
No, I'm good. Sorry.
No, you're good. Anyone else with thoughts or comments? Jen, I saw you unmuted as well.
Thanks, Dr. Miller, for that talk. I think, and I think I've heard you use this word before. I think one of the key words, there were a lot of great tips, but I think finesse is one I'm going to take away, because it describes sometimes what you have to do in order to get through some of these situations that involve many people. And while you're honoring your patient, you're also trying to keep them safe. And it's interesting in my practice, although I have patients who have dementia, who have adult children as caregivers, I also see a lot of couples where the spouse is the caregiver and there's not an option for an adult child. And those, to me, especially the older the couple, the older the spouses, are the most frightening, because they just seem one small thing away from
Trouble themselves.
the couple.
Yep. Yeah, I'm glad you brought that up, because I've seen that a lot too, where the quote-unquote caregiver is an ailing spouse themselves. And it may be ailing physically, or maybe they're on the road to dementia too, and they're both getting demented. I've also seen it where oftentimes the first one to start to show problems gets passed up by the other one, who gets even more sick and goes on and dies. And so then your demented patient is the problem. I'll tell you one hell of an example is we had an aging professor who was dementing, and he was getting examined in our office when his wife had a heart attack in the waiting room. And she went into pulmonary edema and was in the ICU. And so that we had to call the ambulance, and they whisked her away. And here we are stuck with him in our office, and he can't drive home. He's cognitively impaired. And the last thing the wife said before she left for the hospital was, "Don't forget the dog in the house."
Oh, oh gosh. Oh.
So we had to get on the phone, call his son in Boston, who said he'll be on the next plane. And fortunately, there were neighbors who could, intervene. And, he kind of sat in our office the rest of the day so we could patch it together.
Yeah, I mean, the patient I presented several months ago who, it's a similar situation, and I talked to her about it. And I think in West Virginia, it's often a good bet to ask about church relationships, pastors, stuff like that. Mm-hmm. And this might be for another echo, but one question that has come up for me in assisting caregivers is, and this might be actually an Alzheimer's Association Hub member presentation, is the process for getting somebody admitted to a nursing home, and it seemed inordinately difficult. I had a patient who was becoming more and more belligerent and difficult at home, and it was there are undoubtedly family practice physicians who are well versed in this, but I'm not. Yeah. So it was really hard for me to figure out the paperwork, and also is complicated, of course, by the fact that this was in the year of COVID, so there were all kinds of extra, and the family was ready to have her placed, and so just that whole process, I think, would be an interesting topic for a didactic.
Yes, and it is generally more messy than clean, and I bet most family practitioners, I bet there are very few who would say they're expert at it. It's never easy. Oftentimes those patients go to the emergency room, they get triaged to a psych unit if possible, and then we try to place them from there. But I run Laurel Place in Elkins, and we have probably 6 or 7 people there now that we cannot find a nursing home for. Either they're on COVID restrictions, or they scrutinize the patients and cherry pick the ones they think they can manage easier. Financial concerns are part of it sometimes. So it can be complicated, but sometimes it's the only option when someone just can't live alone. But we should have a social worker, come talk about that.
Yeah, maybe if any of the Alzheimer's Association folks had any comments to that as well, feel free to chime in too, because I'd be curious about that. Teresa?
Mitra, you always read my mind. So I actually get this call a lot. Mom has been in the hospital. She needs to go to a skilled nursing facility. No one will take her. Mom went here. She needs to go to long-term care. We can't take care of her. We can't find a location. So sadly, I don't think there's a great answer to the question right now. I actually am having an ongoing conversation with the West Virginia Ombudsman. They really don't seem to have a great answer for it either. Of course, I'll say back in the day, the process was, you really couldn't discharge someone to home if they weren't appropriate to go home. We always had to find a place for them to go. But that with COVID and just recently, that just doesn't seem to be the case. So I don't know if that really helped at all, but it is a discussion that we are trying to have. I'm also in conversation with the primary care physicians, just to kind of see what we can do to help the situation. Because as of right now, there's really no one to help in the process of getting someone admitted into a long-term care or even skilled nursing facility.
So I was going to ask a quick question to Jay. And wonder, when things like this come up, is there a possibility that we can tap into the practice-based research network to, come up with a list of possible questions that we want to reach out to and get kind of survey responses from people around the state about resources?
Well, Mark, that question should also go to Jennifer Boyd as well, as she's one of the co-directors of the PBRN. Yes. But Jen, I'll let you take it away. I mean, we're always open to opportunities, but Jen, go for it.
Yeah, so it's a tricky question to answer because the PBRN is a great resource for having contact with people in primary care across the state. However, because there's such a great interest on the part of researchers to survey, what we've done is we've developed something we call our core survey, which is a survey that goes out once a year and it includes about between 30 and 50 questions. And there's an application process that goes through our an ad hoc committee of our steering committee. And so the answer is both yes and no. It is possible to survey, but it's an application process to be able to do it so that we're not constantly, inundating busy clinicians with surveys. So the other thing that comes to my mind is we have an annual retreat, and the topics for that are both member driven and steering committee driven and administratively driven. And so that's a pretty interesting point that I think Jay and I could talk about, is that when things come up in this or other echo sessions, the retreat might actually be another opportunity to query membership or get feedback from membership.
Thank you. It makes sense for us. And you know what, the survey just kind of went out. I got a message about it recently. And so going forward for next year, keeping track of some of these topics so that as a group, as an ECHO group, we might be able to kind of think about, is there something in particular we want to add to that survey? I think that's an interesting idea. Thank you.
And we have some other ECHO things, Jen, that we can talk about as well for the retreat, but we'll add this definitely to the list.
Yeah, I think it's a great idea to keep that core survey of the PBRN in mind as a way to reach, potentially reach a broader network of clinicians to find out what's going on when things come up during an ECHO.
I'd like to ask Mark a question, if I could. This is Kirk Wilhelmsen. I'd like to ask him a question. I've only been in West Virginia for a few months. I knew what to do in North Carolina if I suspected elder abuse or both physically and financially, but I don't know what's our obligation here and what resources we have for helping people.
Was that directed to me or Mark Hout?
Dr. Williamson, you're muted right now.
You take it, Mark.
Okay. I assume it's the same here. I came from Pennsylvania, where it is a reportable offense if you come across elder abuse. It's like child abuse. You have to report it. And then adult services are the ones who go out and investigate. My experience with them has been mixed. Sometimes they go out like a bull in a china shop and and really shake things up and upset everybody in the process. Other times they go in and they say, we asked everybody and they said, no, we didn't. And so we closed the case. So, you know, it all comes down to the individual, I guess, who you're working with. What I've tried to do in the sort of finesse realm is find out, you know, sometimes it's one child who is doing the exploiting, for example, to find out if there are other family members that you can gather in this circle of caregiving and kind of get a sense of whether they're aware of what's going on and whether they would approve or not approve. I worked with a family with an aging, dementing mother for years, and the one daughter moved in to, quote, help her out, and was selling her belongings on eBay and basically stealing from her money as well. And so the other siblings found out and threw a fit and threw her out and were threatening to file charges, et cetera. So, you know, it's rare that we have to be the enforcers, but if we're aware of it, then we take action. I had a case in Pittsburgh once, and you could argue this is potential abuse. The driver who brought the patient in from a personal care home passed by me in the hall and reeked of alcohol. And I pulled her aside and I said, I'm smelling alcohol on your breath. She said, oh, it was my birthday. We just had one. And I'm like, it smells like more than one to me, because it's thick in the air here. So make a long story short, we said, you're not driving this patient home. We called the company and said, send us another driver. And I don't know what happened to her, but she started to cry and say, you know I should have gotten help for alcohol, blah, blah, blah. And I said, well, you know, maybe it is time, but you have to do what you have to do at the moment. So all I can say is we advocate the best we can. You know, I don't think it's up to us to say, you know, look, we're going to call the Attorney General, unless, I mean, they do want to know about these things. And the big one are scams, you know, IRS scams. You won money. I had a patient in Pittsburgh who was wiring money out of the country to these scammers who said, you know, once the word was out, it was like they were piranhas gathered in the water. All these other sweepstakes scammers were mailing things to his house, and he couldn't tell the difference. And his son eventually had to get involved to keep his money from being completely, you know, siphoned off. So I think that's probably, you know, physical marks on somebody, patients telling you they were locked in the house and couldn't get out by somebody, you know, those would be an APS referral. And the financial stuff, APS also, but maybe tell them, you know, whoever recognizes it, to talk to a lawyer or even your local police. You know, they're trained to some extent to start the ball rolling for, you know, the protection of the vulnerable.
Thank you so much, Dr. Miller. I apologize, I have to kind of cut in here. We are at the end of our hour for the session, and it's been such a great session. Before we jump into the announcements, I did want to give Amy the floor for some updates she has on the association. So Amy, I'll just give you the floor.
Oh, okay, thank you. I'll just quickly give the announcement and then make sure I follow up with you, Mithra, on the links. Tomorrow we have our health equity seminar, so just a reminder about that. That's tomorrow evening. Mithra sent out information about that, so there is the link on how to register, but we do have a speaker from WVU joining Ohio State University, University of Michigan, so we're excited about that. Also, our 2021 facts and figures was just released today. So I will send a link for that, but if you are interested in learning how your state is doing compared to other states around the country, see the latest trends. Our special report is on health equity this year. please take a look at that. And then finally, just save the date, and I will make sure we get information on this, but our Advocacy Day is coming up on March 17th. It will take place virtually at the noon hour. So we have some virtual sessions with our lawmakers in West Virginia. So if you are passionate about policy and advocacy, we encourage you to join that as well. Thank you.
Thank you so much, Amy. And thank you, Dr. Miller, for that awesome didactic. So glad you were able to do the part 2 of that. Before we part ways, I wanted to turn thanks to Elizabeth for the announcements for next time. Thanks, guys.
Great. Thank you, everyone, for joining again. So our next session will be April 6th. Again, we're going to do that from 12 to 1. Really great turnout today, so we appreciate everybody's time. If you have any questions, please reach out to one of us, and look forward to our beautiful announcement reminder that we take lots of time to make that artistically perfect on. So if you have any questions, please reach out and have a beautiful day.
Thanks, guys. Bye.